my, show and tell stuff.
This is your show and tell.
Yeah.
We'll just hold it up.
Okay.
They'll be able to see.
Like
You'll
that.
be fine.
Okay.
All right, I think we'll go ahead and get started.
Okay.
If you haven't, make sure you please sign in
perfect.
and grab an evaluation form to help us craft future CME programs. I'm excited to have a visitor here today from UnityPoint Clinic. Dr. Lewis is a specialist in infectious disease. He's boarded both in ID and internal medicine. He has subspecialty training in the treatment of HIV. Today, he's going to go a little bit off his subspecialty training and give us a very seems always to be a timely topic, infections in travelers who are coming back here into the state, and specifically viral infections. And I know he's been working very hard in this presentation and is looking forward to give it. So please help me welcome Dr. Lewis.
Thank you. I hope you can all hear me. Can the people at the back, Dialis, can you hear me? Okay, great. I'm very bad with electronic stuff. The only thing I know is how to take a sledgehammer to it. All right. So without much ado, I just want to tell you that this topic came about because Dialis and I were talking about what would be good to entertain you all with an educational perspective and bring to your attention some of these infections that we as travelers these days don't pay attention to until we hit it head on. And I think we also have to understand that infections are a little bit like the fashion field. For example, last year everybody was jumping off their seats and through the roof about Ebola. A few years before that, it was SARS. And then I think somewhere in the middle, we lost the MERS. And I think a decade ago, it was avian flu. So we were shooting all the birds coming from Canada. The Canadian geese are bad, aren't they? So my whole idea here is to kind of get you through a little bit of what travel medicine is. The fundamental basics, which is right here. So I wanted to make it like a show and tell. And as well as give you fundamental points to take home so that when you encounter patients, because we hardly ever see travelers come to the clinic. After they get a shitload of diarrhea and all that stuff, everybody wants to be seen the day before. So what we want to do here is to help them prevent those things from happening. And that's the whole idea behind the talk. So I'll go on to my second slide here. Identifying the risk of who is an at-risk traveler. And I think if you look at medicine in general, we try to divide them under the immunocompromised category and the immunocompetent. The worst amount of patients that go in are immunocompetent patients. And I think the infections, if you look at it, is usually in the category that we call VFR, visiting friends and relatives. And the reasons why they get the most number of infections as we go along will be pretty evident. Then there's the very uptight corporate travel person who doesn't step out of their five-star hotel and the aura that comes with it. And that's good because their risk of infections are going to be the low. Then there's a whole lot of category, people who study abroad for extended periods of time, those who go on mission trips and get infections and come back, those who go for disaster relief and unfortunately get infections as well. And then there's the travelers like in the cruise ship. Then amongst the immunocompromised, I think most countries these days still freak out about HIV. So if you're HIV positive, there are a list of countries that may not permit you in, or if they do, they make you go through the hoops. We won't talk about them. Then there's a category that I don't think we recognize very well, which is the asplenic. And when you look at functional asplenia, that's a whole paragraph in itself. All right, so let's talk a bit about the visiting friends and relatives. There's many definitions of what it means, but basically what it means is that you have citizens who are newly of a country who go back to the country of birth or origin to visit family and friends. And that puts them at a higher risk of infections because the immunity that they did have before they immigrated, it was probably gone down. Now, why is it that we have barriers to protecting these people? Now, you'll see in my slides that I put all the references down there. This is from Travel Medicine 3rd edition, Keystone and folks. But you'll see that the vast majority stems from one single source, which is the CDC and the Yellow Book. And we'll talk about that because I think that's one of the most important resources of information, not just for us, the healthcare personnel, but also for our patients. Okay, so getting back to visiting friends and relatives, there's a lack of perception that they are at risk for infections. Oh yeah, I used to, live in the country, all the mosquitoes know me, generations after they still know me. I don't think so. Believe that the disease is not present. Oh no, these days malaria doesn't exist. Ebola, it's just science fiction. When you get stung, whoa. Lack of awareness of health services. Most of you may not know that there are travel clinics. Patients may not know that there are travel clinics. And then, of course, there's a language barrier. I'm speaking English, they're speaking French. This happens quite a lot. And, I'm speaking French, they're speaking Greek, or things like that. And I think we in the medical field have begun to realize that language barriers are a significant impediment for patients getting care. Then there's, of course, the big money, the financial barrier to care. I mean, anybody who gets whopped like I did recently with a $500 bill for a healthcare visit is going to think twice before they say, oh, well, I'll take that diarrhea, it sounds much better. Right? Fear of authorities. I don't think I need to elaborate more on that. Every time I fly through TSA, I'm in fear of authorities. Then there's healthcare provider lack of awareness that this, is a risk factor. And then differences in belief systems, whether that be religious, whether that be political, whether that be, any other factors. These are all risk factors that put this category of patients at high risk for infections. Now, let's take a look at the mode of entry of infections. There's many ways you can get an infection. You can just sit there in the sun, get bitten to death by mosquitoes. Then you can get chikungunya, yellow fever, dengue, just run down the list. Now, you could be visiting somebody who's got sniffles and they're coughing all over you, and then you get all those right up there. Now, you could be eating the wrong food, and then you could be getting a whole lot of stuff. Bites. And this is what I call kuchi kuchi kuchi. You go see a nice cute little puppy and want to pet it, and its mama dog comes and bites you. Now you're at risk for rabies. Now, why do I bring up all these? Because, these are things that we don't think of or plan for until we get struck by it. Now, there are some diseases here that are sexually transmitted or due to IV drug use. And there is a category of at-risk travelers who go abroad for sexual activity and so on and so forth. And they are at risk of getting HIV, viral hepatitis, whether it be Hep B or Hep C. And what I've tried to do here is to give a balanced view of infections that normally an ID person doesn't talk about. So the infections that I'm not going to talk about are influenza, measles, the HIV, and the hepatitis, because I think, a different podium is required for those kind of talks. But the ones that are barely glanced at, maybe today we can do a discussion on that. So with that said, I'll also show you how we can prevent some of these infections. I stress to all my patients the necessity of getting a flu shot. And I'm dead tired of hearing excuses after excuses, and I think I've heard the boatload of them about why a flu shot almost killed them. And I want to tell them, if you haven't died, go get a flu shot. It probably is going to prevent death. Then there's the measles, and I'm so glad that I don't do pediatrics anymore because, if one more parent tells me the autism, what do you think about autism and measles? I think I'm going to have an instant seizure. Then we have viral hepatitis A. Then we have the polio, which I think most of us here are not aware of, and that's how it should be because we've completely eradicated it from the Americas, but there are still hot spots in the world, and I want you to be aware of them. Then there's yellow fever, the hepatitis B, the rabies, the rotavirus, and the Japanese encephalitis. Amongst these viruses, I won't be talking about the rotavirus and the hepatitis, the influenza, and the measles for the reasons I just outlined a few minutes ago. All right, so we talked about VFR, how to protect them. Let's hit the first infection. We're going to talk about chikungunya. Why chikungunya? Well, there are some infections that are emerging, and chikungunya is one of them. It started out in the, I would say, the Eastern African islands, and then it started to spread worldwide, almost in a fashion similar to West Nile. It belongs to the virus family called tocovirus, and it is spread by the Aedes mosquito. A unique factor about the Aedes mosquito is that it bites during the daytime, and it actually finds home in water that is standing. whether it be in tires, which you'll find discarded all over, or on pots which have standing water, or in areas where there's no running tap water, you might find that there is buckets filled with water that's uncovered and a perfect breeding ground for the Aedes mosquito. Now, how does this differ from malaria? Well, the malaria mosquito usually bites during nighttime, and it is the Anopheles mosquito and not the Aedes. So, knowing the patterns of the day or night, malaria mosquito bites at night. It's a night visitor, whereas the Aedes really doesn't bite at night but catches you more in the morning. The hosts are humans and non-human primates, and the incubation period is very short. It is usually less than a week, whereas the malaria usually takes a week or longer to in fact get into that schizoid stage, which affects the liver. Asymptomatic, about a quarter of patients are asymptomatic. So you will find that those who come down with chikungunya, the vast majority are symptomatic. And like I said, in the last decade, we have seen an emerging number of cases of chikungunya. We'll go over the numbers in the next few slides. And when the patients are identified with chikungunya, one of the things that we need to do is avoid getting them bitten by the local mosquitoes. Why? Because we have a lot of Aedes mosquitoes around. You get them exposed to this, and that could probably circulate in the community. This is how the wonderful Aedes mosquito looks like. If you see it, smack it. Please don't pet them. Try to make them pets. Okay. Vast areas of the world where the chikungunya epidemic has erupted. And as I kind of said, the Comoro Islands here in Africa probably was the epicenter, and it spread into the mainland, and then from here into Asia, and then worldwide. You can see in Europe, there's a strong Italian and French connection. It must have something to do with the football leagues, I'm supposing, but I might be wrong. Okay. All right. Let's take a look at what we have in the US. All these states, except I think that's North Dakota, and this is probably Montana. Dick Cheney probably visits those. So it's chikungunya free. I'm just kidding. Okay. Reported number of cases close to 2,500. And the vast majority of cases are imported from overseas, just as we saw in those slides. So again, informing and educating the traveler is important. Why? They can bring it here and then lead to a local spread. And here's a local spread. Right now, it's less than 1%. But if it takes off, just like West Nile did, then you'll have a whole new epidemic at hand. And here it is in Florida, where you have locally acquired cases of chikungunya. All right. Now, what's the most important differential before we get there? What's the most important clinical findings? High fever, arthralgias. I think my mom got this about 10 years ago, and she was complaining of severe joint aches. She didn't have any joint swellings, and at that time we were like, oh gosh, we don't know what it is. And that's when the headlines started saying a few months later, chikungunya. Sometimes after the acute episode is over, you're left with debilitating tenosynovitis, joint pain and stiffness, and really we don't know why that happens. One thing, although it hits you hard at first, fatalities are very rare, and these chronic conditions that I just mentioned above are very far and few between. Now, as with any other infection, comorbidities that increase the mortality, older age, hypertension, diabetes, chronic heart disease, and so on and so forth. Now, features about it. Usually the joint symptoms, like I said, very severe, debilitating. Patients can't really, ambulate as well as they did before and carry out their activities of daily living. But you will find that it's symmetrical in terms of how the joints are affected. Usually it's the hands and the feet. And the fevers, which are high, can have a biphasic pattern. They come, they go, and then there's another fever spike that happens. The differential diagnosis here is very important, especially for us practicing here. Why? The first differential diagnosis here is dengue. When you compare chikungunya with dengue, we have to make sure that the patient doesn't have dengue because the mortality and the treatment outcomes are different. Then, of course, there's leptospirosis with the bacterial exposure to, to urine material from either rats or canines and so on, malaria, rickettsia. Amongst the viruses, I've found that there are some unpronounceable names like Onyong, Mayano. God, I don't know where these things come out from, but these are all in your differential diagnosis. If at night if anybody has sleeping issues, insomnia, I suggest that you read these slides and they'll knock you out. All right, so we'll focus on dengue because I think the treatment outcomes, like I said, do matter in that aspect. Chikungunya and dengue, well, they're both transmitted by the same Aedes mosquitoes that I showed you. Diseases have similar clinical features. They can start off with high fevers. You can have the arthralgia, the myalgia. Very difficult clinically to draw a differentiation. And they usually can cause co-infections because they circulate in the same area. So here we are, a little clinical chart that differentiates between the two. You can see that arthralgia is more common with chikungunya, less with dengue. And dengue is usually known for its myalgia and the term break-bone fever. Now, when you look at outcomes that are detrimental, hemorrhagic shock with dengue, there's a variety of it called dengue hemorrhagic fever, and dengue with shock. The shock aspect of dengue is usually from leakage of plasma, and we'll talk about that in a few minutes. Then, lab features, usually you see lymphopenia, not really severe neutropenia, and these patients don't need to be on neutropenic precautions because the incubation period is so short and the treatment is so clinical that you really don't have to do anything. These counts usually recover on their own, with the exception of dengue, which we will talk about because of the hemoconcentration that you see out here. All right, then complications. Rarely chikungunya infection can lead to myocarditis, uveitis, Guillain-Barré, paresis, and encephalitis. Diagnosis, they do have these testing, which is for the IgM, which is the early response to the humoral, and the IgG, but these are not FDA approved, and you can go through your state lab to figure out how this can be done. Treatment, really symptomatic, rest, use of IV fluids as needed, and use of analgesics and antipyretics. No antiviral treatment exists for this, and as of yet, we don't have a vaccine. Just in the last 2 months, I think the New England Journal put together a very good article on chikungunya, so those who want to read more about it, I strongly recommend taking a look at that. All right, without much ado, let's talk about dengue because these two things are very closely related. Now, this is caused by a flavivirus, and I think one of the common things that we think about when we talk about flavivirus is hepatitis C. Again, transmitted by the infected female Aedes mosquito bites. Modes of transmission, usually mosquito bite. Other modes of transmission are blood-borne because in the early incubation period, you might transmit it. Organ transplant can rarely lead to that, as is perinatal. Now, the incubation period of dengue and chikungunya, almost the same, less than a week. And as I said, it's like the break-bone fever is the classical clinical description for it. And in severe illness, due to the plasma leakage from the viral infection, shock as well as bleeding from thrombocytopenia can develop. Areas affected by dengue, almost again in a very similar pattern to chikungunya because the vectors are in the same areas. So in Central and Southeast, as well as Central South America, we don't have endemic dengue here. Then you have Sub-Saharan Africa and parts of Middle East. And then as you go to the southeast part of Asia, you can see almost the entire Indian subcontinent is covered, and a little bit of Australia here in the Queensland northeast area. So what can we do about dengue? We can diagnose it early on with a PCR and later on with the IgM. Now, one of the clinical determinants of whether this can be a patient presents with dengue versus malaria is to look at the incubation period. If their fever starts while they are there in the foreign country or within a week after them being exposed there, it's probably dengue and less likely to be malaria. As I said, malaria incubation period is usually 10 days or longer. Now, when you treat somebody with dengue, realize that there's no specific antiviral medications. And you may want to avoid NSAIDs just to reduce that bleeding potential. So things like aspirin and Motrin, these may be drugs that you want to take away from them. And fever can be controlled, therefore, with drugs such as Tylenol and sponge baths and so on and so forth. Again, chemoprophylaxis for this as opposed to malaria? Nope. Vaccine for it? Nope. When do you need to admit them? If they're doing very clinically bad with severe thrombocytopenia and hemoconcentration, I think it's probably best to put them in an ICU setting and give prophylactic platelet transfusions if they are at high risk for bleeding. Have they been found to be useful? No. And can they contribute to the fluid overload as with plasma leakage? Yes. So be very careful in treating them and monitoring them. Okay, now we come to MERS. I think last year in this whole Ebola outbreak and the hangama and the hoopla, this virus got completely lost in translation. Now, it's a newly discovered coronavirus, unlike any coronavirus that we know of. Now, if we think of coronavirus, it usually causes upper respiratory infection. But this one has a mortality rate of about 30 to 40%, whereas the normal coronavirus wouldn't kill a fly. So that's why I just wanted to bring this into perspective. How did it emerge? We really don't know what the true host of this is. We believe that the camels are intermediate hosts, and that coming in contact with sick camels probably led to the spread to the humans. The incubation period is about a week, but can range anywhere between 2 days to maybe 2 weeks. Now, countries with confirmed MERS where there is endemic disease, well, the entire Arabic nations in the Arabian Peninsula, I think, should be included our host Saudi Arabia. And then travel to those countries is where I think patients in the US and the Western world come with MERS. Again, we haven't seen endemic MERS activity happening in any of the countries on the right side of the column. Now, in 2014, 2 cases of MERS were confirmed in the US, one in Indiana and one in Florida. The reason I knew about the Indiana was I got a call from one of my in-laws saying, hey, should I take any precautions for MERS? And I gave him a list of things that chewed his ear off, starting from taking the flu shot. And I said, if I hear that you died from the flu shot, I'll kill you. And then I said, he said, what else can I do? And I said, don't watch NFL games, don't watch, this, that, and the other. And finally he said, I'm not calling you for any health reasons. Turned out good because the MERS epidemic never hit the national media. So both of these patients were healthcare providers, and they probably came in close contact with patients who had MERS and acquired it. They traveled to the US from Saudi Arabia. Both were hospitalized and recovered well and went home. Now, I want to take your attention to this last sentence here. A few people became infected with MERS after having close contact with an infected person who had recently traveled to the Arabian Peninsula. So what does that mean? I showed you the charts earlier, the saying that, you had to really travel to the MERS endemic countries and then get MERS. So I think this is an epidemic that needs a lot more studying to figure out where its source is, what is its real host, and what are the vectors or transmission risks. So in the meantime, what do we do about it? Let's take a look. There's a lot of stringent criteria for it. Like I said, it looks just like an upper respiratory infection that takes on an acute and severe onset. So fever, cough, shortness of breath. It really doesn't tell you what it can be. It can be influenza. Then you can have GI symptoms. Again, influenza can have the same thing. So the timing, whether it's in winter season or whether it's in summer, might help. Severe complications include pneumonia and renal failure. And like I said, the mortality is about 30 to 40% as they estimate right now. And these are just rough figures. Now, most people who passed away did have underlying chronic medical conditions, such as diabetes, cancer, chronic visceral organ damage like lungs, the heart, and the kidney. Now, this is what I found very interesting. I was trying to say, how can I get people to buy into prevention? Okay, avoid contacts with camels. I suggest you don't take a walk down your pathway today. You might run into camels. Okay, do not drink raw camel milk. I can totally understand that. Do not drink raw camel urine. Seriously, are we exporting or importing camel urine now? Oh, la la la, good, 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 good. I was like, okay, this doesn't make any sense. But I'm supposed to warn you, don't drink raw camel urine. Do not eat undercooked meat, especially camel meat. I'm sure the cafeteria is not running to get this. Now, jokes aside, how do we work if we have a patient who comes in with MERS? I mean, I think the Ebola epidemic taught me a lot of things. Panic. The first thing in infectious disease that I've tried to learn is how not to panic, and now how not to transmit that drama of panic onto the rest of the people, and then the patient, and everybody wants to know, are you Jesus Christ Superstar? No. So what we need to do is figure out, okay, in a particular patient, what are the modes of transmission? So somebody who has, say, pneumonia, somebody who needs to be intubated, and therefore are at risk for aerosol generating procedures, probably airborne precautions. Somebody who's got diarrhea with MERS probably requires, contact precautions. And those who are having a cough, of course, droplet precautions. So I look at it from a very simple perspective of saying, what is the mode of transmission here that I'm seeing, and what should I, take on? And that, when you speak of, I think reduces the volume of anxiety and bad decision making that anxiety can lead to, like in a domino effect. So let's see. Is there any vaccines right now for MERS? No. We don't even know what the original host of this is. Is there any antiviral treatment? Not yet. Is there evidence for human-to-human transmission? Apparently, there's some limited evidence for this. And I think the most high risk would be in aerosol-generating procedures, like in a bronchoscopy, maybe the close contacts of people who are present at intubation and so on and so forth. So that's MERS. In general, just avoid the camel. Don't smoke camels either. Okay. I'm supposed to give, tips to stop smoking, and aid smoking cessation. So all those farmers in Virginia, I think are rounding up to shoot me. Japanese encephalitis. Now we talked about MERS, which is an emerging infection. Let's talk about an infection that has been present for years, and we hardly ever see it. I think as a medical student growing up in India, I think I saw maybe one case of Japanese encephalitis. And at that time, it was a clinical diagnosis and not lab obtained. The virus is by itself called the Japanese encephalitis virus. The vector, a little unique, it's the Culex mosquitoes. I didn't find any cute photos of the Culex, but I thought I would horrify you enough with the Aedes. So it's a very different mosquito. Aedes has a daytime biting pattern. Culex has a nighttime biting pattern. The incidental host or the accidental host are we humans. We step into the life cycle of the Japanese encephalitis virus and it gets into our body. Incubation period up to 2 weeks, maybe 15 days, so on and so forth. Where do you find it? In Asia, Southeast Asia usually. And which parts of Southeast Asia are affected? Rural agricultural lands, especially where rice paddies are, where there's a lot of water that's standing. Now, it can occur in persons of any age, but the symptoms usually are in less than 1% of people. So most people who get bitten don't have any symptoms. Is there a prevention for it? Yes, there's a vaccine for it. How much is my success rate? 0. I can't get people to take a flu shot. I'm going to get them to take a Japanese encephalitis. Okay. Treatment, supportive. No antiviral medications for this. Case fatality rate is about 20 to 30%. And I think you also have to think about what are the outcomes. There are certain people who can get neurological outcomes, and that adds to the case mortality. And as you can see, here's Japan, and here's the areas of viral spread, including the tip of Australia. So who needs the vaccine? All right, lab workers who have a perverse pleasure of working with Japanese encephalitis virus. Hi, I work with Japanese encephalitis virus. Shoot. Travelers who spent more than a month in areas where they can get Japanese encephalitis virus exposure. Go ahead, give them a shot. For the rest, it's really a question of, do you really need it? I mean, the cost of the vaccine versus, who really comes down with the infection. It's 99% asymptomatic. And as you can see, the number of patients since 1992 that have been reported in the US is about 4. So, do we need to go out there, buy the vaccine and stock it in the travel clinic? Probably not. Rabies. So earlier, I talked about this Chikungunya virus. Yeah, this is a perfect example. I was teaching my kids, the other day, and I told them, you go to India, that's fine, I like that, but don't go and say, hey, doggy, 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 and get bitten, because out here we vaccinate our domestic animals, dogs, cats, and so on. But internationally, dogs are one of the leading sources of rabies. And about 40 to 70,000 people still die each year from rabies. I think 2 of the most traumatic deaths that I have seen as a physician was one tetanus and the other one was rabies. And rabies is fatal. There is really no treatment once it sets in. And most of us, thank God, we haven't seen it. My hope is we don't see it. All right, so what are the things that we need to avoid? All species of mammals that are warm-blooded can carry the rabies virus, and it's usually transmitted in the saliva, usually by bite. Less likely that you have an exposed area of skin, such as an ulcer, that people would, let their animal friends lick it. Now, mind you, I've seen weird cases, but I won't bring those here and make you all puke. In the US, the non-domestic animal reservoir usually skunks. I think we all generally tend to avoid the skunk. I don't think anybody applies to get a skunk as a domestic pet. Then there's the cute little raccoon that has pile of raccoon shit when they form a colony that has Balis ascaris and so on. But we won't talk about them either. And we'll talk about foxes and coyotes. I don't think anybody keeps any of these as pets. We do get questions as to, hey, I got a rat and it bit me. First, why would you keep a rat? 2, do I have risk for rabies? No, I don't think so. You don't have a risk for rabies. But if you did have a woodchuck, your risk for rabies might go up. And that's one of the reasons why I won't watch, Groundhog Day, because I heard there's a woodchuck in it, and I'm afraid that it'll jump out and bite me. Like Cujo, I'm just kidding. The thing that I also want to talk about is bat bites. Now, bats, their teeth are very small, and if they do bite, it's not like the dog teeth, which lacerates the skin and it's evident, oh yeah, you got a dog bite. Bat bite is hard to often find. So if you find a bat flying around your room in the middle of the daytime, A, the bat got lost, or it's a rabid bat. It may need to be tested. So things to think about when we talk about rabies is, if you are traveling to parts of the world where domestic animals are not protected against rabies, and you have not taken a rabies shot in the last 3 years, that your risk therefore does exist. So rabies is present on all continents with the exception of Antarctica. I don't think there's travel tours there. Highly variable incubation period, lasting anywhere from 30 to 90 days. And like I said, once the onset of the disease happens, especially with spasms of the swallowing muscles like hydrophobia, it is an irreversible condition. There is no known cure, although this Milwaukee coma protocol is a treatment option, and it is available through the Wisconsin Children's Hospital, I believe. Now, when we talk about rabies, there's also one aspect that I want to talk about, which is avoiding animal bites. Avoid feral animals and be aware of your surroundings. Do not accidentally surprise a dog. Dogs like being petted, but don't go behind it and say, hello. There's another thing about animal bites, which is monkeys. They look very cute. They're really another one of those kuchi, nice looking creatures that we go after. But when you get bitten by a monkey, there's several things to consider. One, rabies, of course. And testing the monkey that bit you may probably be impossible because it's hard to catch them. Once they bite, they run away. And then the other virus that you have to think about is Herpes B Virus, which can also be just as deadly. So if you see monkeys in areas that you're visiting, whether it be next to your hotel or whether you're going to a shrine, just pay attention to the hotel and the surroundings and pay attention to the gods that you're visiting, not the monkey. So that's just what I wanted to kind of talk about. As I said, human rabies in the US, very rare, about 55 cases since 1990, but worldwide, the mortalities are still pretty high. Wound care. Good wound care actually can reduce your risk for rabies from the very get-go. And then, I think one of the lessons that we are taught is whenever we see a wound, run in and suture it. And sometimes we may need to take a step back from that practice. That's almost like a reflex to say, does this wound need to be sutured right now? If for cosmetic reasons, yes, probably. But then try to use the rabies immunoglobulin to the most effective. And I just put that line there because I've been asked once, can I use a local anesthetic while treating this wound? I was thinking about it and I said, the poor patient is traumatized. Now you're going to traumatize him or her further by shooting the immunoglobulin in there, and then you're going to bring the big suture and you're going to go suture it without a local anesthetic. I think I would give it. But I had to look into the risk, all the resources before I came up with that answer. So if there's an ID physician here, I hope I've made your job easier. Can I give local anesthetic? Yes. We talked about wound care. Rabies vaccination, the series are usually 0, 3, 7, and 14 after getting a bite from an animal that's confirmed to be rabid or highly suspected to be rabid, and if you're not previously immunized to rabies. Previously immunized to rabies within like 3 to 5 years, I think you just need 2 shots for booster and you're done. What I haven't shown here is who needs rabies vaccine and who doesn't. I thought about it and then I said, I'm not going to bore you with one more slide that shows columns. But basically, not every traveler is at risk. But if you do get rabies exposure and suspected, you have time to get this tested and treated out with vaccination. The other thing about the vaccine is the short life expectancy of the vaccine effect and the cost. It's very expensive, a vaccine to deliver. So not everybody needs to go get a rabies shot, especially if they're corporate travelers. Now, when you're visiting family and friends and you're going to be exposed to the dog or the cat or so on and so forth that your family has and hasn't been vaccinated, yes, this does become a concern. Again, the question is, do you really need to pet them? I mean, those people are there petting them every day. Do you really need to come from here and go pet them? I don't think so. All right, let's talk about yellow fever. Yellow fever, yellow book, yellow fever. I myself was getting feverish when I started to read this topic because I was like, I don't think anybody here will really like it. But it does have important travel implications. Again, as you can see, the flavivirus is the one that is associated with it, and this belongs to the vector, the Aedes mosquito group. The reservoir is usually between human primates and non-humans. And I think as we come closer to the city or the urban lifestyle, it's human-to-human transmission. And as we go closer to the jungles, it's more non-human primates to humans. Again, another reason not to monkey around, In clinical presentation, again, asymptomatic in most patients. However, in about 15% of patients or so, they can be the toxic form where patients can go into hemorrhagic shock and be jaundiced and have multi-organ failure. So when it does progress into that severe form, the mortality increases. Yellow fever endemic countries are usually in the sub-Saharan Africa and West Africa. And when I show you the next slide, you'll realize that if we put together South America and Africa, it's almost like when the world once existed together, the Gondwana or whatever they call it. This is exactly the areas of spread. And maybe these vectors have been around. And maybe this is what caused the dinosaurs to die. Who knows? Dinosaurs died from yellow fever. Whoa. All right. Serological diagnosis, IgM, IgG, but there's a lot of cross-reactivity. Like I showed you, these are flaviviruses, so it may pick up something else. Antiviral therapy, none. Treatment, therefore, is again symptomatic. Rest, fluids, analgesics. And because of the hemorrhagic risk, I think it's reasonable to avoid using drugs like aspirin or NSAIDs. And very important, somebody's got yellow fever. You want to protect them from exposing the yellow fever virus to the local breed of mosquitoes. Like I told you, the Aedes mosquitoes are ever ready and waiting. So we want to kind of protect our Aedes population from that. Is there a vaccine? Yes, actually, finally, there is a vaccine, I should say, amongst all these diseases that I talked about. Risk, very low. in the last, say, 5 decades, about 9 cases of yellow fever were reported. Now, mind you, because of asymptomatic infections, maybe those others who got it never got reported because they didn't present to their physicians. Countries that require yellow fever, usually in the West African and Central African areas. Then who can and who cannot get yellow fever virus vaccine? So this is a live virus, and the idea behind it is that you don't want to go and give somebody yellow fever, right? Because it's a live virus and that can cause the disease in itself. So the people that you want to avoid are those who are transplant hosts on immunosuppressive medications, those with primary immunodeficiencies, which are very rare to find, things like DiGeorgi syndrome, so on and so forth. Those who are taking immunosuppressive medications, probably things like for rheumatoid arthritis and so on, especially heavy doses of prednisone, and thymus cell disorders. Now, HIV. Look at how the wording is. Symptomatic HIV or CD4 less than 200. If you take a rough estimate of patients these days with HIV who follow with their clinicians, I think most of them are in the 300, 400 range. So HIV by itself is not an absolute contraindication. The advanced stage of HIV disease, which is what this states, is probably a contraindication. Age less than 6 months, an allergy to vaccine. The rest are all precautions, but not a contraindication. So for example, elderly patient can get the yellow fever vaccine. Pregnant patient can get the yellow fever vaccine. Breastfeeding, yes, not a contraindication, but it is a precaution. Precaution is where we hedge our bets and say, we don't have evidence that it'll kill you, but you should be careful. Polio. Polio is one of those viruses that we have eliminated from the Americas, and that's a really good thing. However, there are hotspots that still have it. And my encounter with polio, I think, coming from India, is that we probably saw maybe 3 or 4 cases that year. And I was involved as any medical student that time in the polio vaccinations to eradicate polio virus. And we were taught a lot of things about polio, how the live polio virus vaccine replaces a wild strain, the concept of ring immunity, and so on and so forth. But I just want to take you through some of the US history that I learned subsequently, which is last case of indigenous polio here, 1979, last imported case, 1986, last case of oral polio vaccine-associated paralysis, 2005. And this kind of shows you how steadily we have advanced against this terrible disease. Fecal oral transmission is how it goes. The humans are the only reservoirs, and countries where wild polio has never been interrupted: Afghanistan, Pakistan, and Nigeria. And I think Pakistan has been in the news these days with polio vaccine workers being shot to death. And I just had a flashback to those days where we used to stop strangers on street corners and give them oral polio vaccines for their kids and so on to try and interrupt the wild virus. And my prayers go to those people who have been killed practicing true medicine. Clinical manifestations. Most patients, again, are asymptomatic. The acute flaccid paralysis that you see with polio is rare. Respiratory failure with people being in iron boxes and all that is, again, rare, and so is death. So, countries that are exporting wild polio virus. Now, I shouldn't say exporting, but that's what CDC says. So Pakistan is right there. Then places like Afghanistan, Cameroon, so on, Nigeria. Countries no longer infected with polio virus, the wild strain, but remain vulnerable: Ethiopia, Israel, and Syria. So I was a little surprised to see places like Israel pop up on that map, but that's very illuminating. Now, what type of vaccine do we have in the US? Well, we discontinued the oral polio vaccine because that can rarely lead on to the virus causing paralysis in itself. And so since 2000, we've had only the inactivated polio vaccine. And it comes in many combinations. You can give it with Tdap, DDAP, BDAP, all this stuff. I'm glad I'm not in pediatrics because those vaccine schedules drove me nuts. Treatment, symptomatic treatment, prevention, of course, the vaccine. At-risk population, who are the people that from here can get it? Those who go in the healthcare settings and work there, those who help refugees in camps, and those who work with humanitarian aid settings. those are the people who are at risk. And you can update your vaccination, depending on what your risk falls into, and the CDC has, several recommendations for that. Now, let's take the last one. I promise you, after this, I won't torture you. It's all done. Norovirus. This is probably the most commonly encountered viral infection that we all encounter. So, again, how is it transmitted? Fecal-oral transmission, person-to-person contact, or sometimes, rarely, indirectly from contaminated food, water, and aerosols from vomiters. Now, fomites can play an important part, and that's what I can try to do with this demonstration here. I can't show you how to bite and all that stuff, and I didn't bring any mosquitoes, okay? So maybe with this one, I can show you how it all happens. Now, let's take a look at the number of cases reported per year. 21 million illnesses a year. How many cases of rabies? 55. How many cases of Japanese encephalitis? 4. Let's take a look at this virus that creeps by and we don't pay much attention to. Incubation period, very rapid. Get into the ship, have lots of stool. So incubation period within 48 hours. Acute onset of vomiting, non-bloody diarrhea. Now, where do we get these? I think we should talk about, settings where a lot of people come together. And those would be your hotels, where you go for travel, cruise ships, camps, and hospitals. What are the foods that can get infected? Ready-to-eat cold foods, those that are not served piping hot, and so on. Raw shellfish, things like that. Role of fomites. So I talked about fomites, and somebody comes in with the diarrhea, doesn't wash their hands, goes and touches surfaces. Somebody comes later, touches that surface, puts their hand in their mouth. I don't know why people put their hands in their mouth, but it happens. Then you get norovirus. Diagnosis, usually clinical, and by the time you get all the labs done, the diarrhea is gone, they never follow up with you. Treatment, supportive care. Vaccine, none. The question of whether to use antibiotics, probably not a good setting, but I do want to tell you that we live in an age, an era of C. diff, and that is one of the tragedies of modern medicine, where we try to fix one problem and end up with one. So if you're very confident that this is a non-bloody diarrhea and a patient has a history supportive of that norovirus, please don't use antibiotics unless there is overwhelming evidence against norovirus. Cleaning up after norovirus, washing hands with soap and water. It was illuminating to see my kids wash their hands with soap and water. Jumped in, jumped out, and I was like, no, you're going to do it for 15 seconds. Most of us don't do it for even 5-10 seconds, so doing it for 20 seconds is good. Alcohol-based hand sanitizers might be useful, but it should be considered a substitute for soap and water. Now, let's take a look at the proverbial ounce of prevention, because I love trying to prevent things from happening rather than clean up the mess afterwards. So, what and how to eat? I think if you can have a fruit that can be peeled, peel it and eat it. If somebody says, hey, let me help you peel it, and they put their hands all over it, please don't eat it. Okay? Things that come, again, in very closed containers and so on like that, yes. And I think what to drink would be things that have bottled water. And be very careful to look at the cap and see that it is actually sealed. Because a lot of times, they break the seal, they sell it to you and say, hi, would you like it for $1? All right. Now, we all like to have ice. So you have your, very strong tea that is boiled, piping hot, and then you put the ice. Did we see where the ice came from? We didn't. Now we end up with, millions and millions of viruses and bacteria and so on. And then fountain drinks. Perfect cesspool for bacteria to, viruses, whatever they be, to grow. So what to eat, what not to eat, I think is a simple demonstration of, how we can use common sense to guide us. And beverages, as I said, boiled water, steam, anything that is served steaming hot, like hot tea or coffee, pretty good to drink. I just want to take your attention to this area here, the last paragraph that says, where tap water may be contaminated, commercially bottled water from an unopened, factory-sealed container should be used for brushing teeth and for practicing oral hygiene. I think that makes a lot of sense, but things like this, we don't tend to remember when we are packing for a trip to the other part of the world. and what not to drink. There's quite a lot of stuff there. And swimming. I think a lot of us love swimming. We jump into the first pool of water that we see, and later when the stink hits us, we're like, whoa, whoa, where did I jump in? Try not to swim when you have diarrhea, because that spreads the disease. And try not to swim when you have an open cut or abrasion. And avoid pools where the water is cloudy. If the water is clean, yes, it's probably a good area to swim. Now, they also say in open areas where, oceans, lakes and all that, try to avoid areas where storm drains are present. Why? In the summer, when it's hot, all the stools, they kind of stack up near the storm drain. And when there's heavy rainfall, guess what's pouring right in? All those zillions of microorganisms that like to use humans as, guinea pigs. Bite patrol. We talked about mosquito bites. The first thing to do is, do we really need to visit that area? I mean, if you're a UN Secretary General and you really have to give a speech, yes, but most of us are not. So the first thing to ask your patient is, do you really need to go to that part of the world? There is an outbreak there. If they still need to, then talk to them about, hey, how about wearing a long sleeved shirt, a long pant, and socks? Treat the clothing with permethrin. Now, if you purchase the pre-treated clothing, they're very expensive. They can range anywhere from $40 to $80 and so on. Apply lotion or liquid or a spray repellent to the exposed skin and know the biting patterns. Now, when we talk about skin repellents, there's quite a lot of options. DEET, anywhere from 20 to 50% DEET, I think is safe to use. You don't have to use 100% DEET. Beyond 50%, the effectiveness of DEET actually doesn't hold up as well. With regards to permethrin, it's very safe. I mean, you can't use permethrin on your skin. You have to spray it onto your clothes, and then you allow it to dry and probably have it after, wear it after a wash. So it takes about 48 hours to plan this and prepare this, but it can help you quite a lot. So what would be my ideal traveler? Somebody like this. Do you see how the socks are tucked in and the pants are put inside? And he's got long sleeve shirts. And he's even got a coat. Now this comes from Tintin, one of the comics that I grew up as a kid admiring. And he even actually walked around in the Saudi Arabian deserts wearing that. So if he didn't die, hey, you won't. What do I want to be? Somebody like this, I want to really, there's this hit girl from Kick-Ass, the movie. And you really want that message to say an ounce of prevention, a little bit of care can actually, make you a safer traveler. And it's not just that you want to not have fun wherever you go, but it's also about having it safe and not bringing something that you want to donate to your neighbors out here. There's a lot of Aedes mosquitoes who do that, so we want to prevent that. All right, with that, I'll finish my discussion and open up any questions, concerns. Gosh, looks like I bored everybody to death, eh?
Thank you for a very informative, and we like the humorous part of the presentation as well. So those of us who are fortunate to be able to do international travel, sometimes get diarrhea in spite of our very good precautions. Lately, I haven't been that, but we've been given like antibiotics, and having been on trips where I didn't take antibiotics and trips that I did with the diarrhea, it's much better on the latter. You said with norovirus not to do the bacteria, and I'm just wondering if your comments in general, and then I have one other follow-up question.
Sure. So let's take a look at how we've gone about in the antibiotic era with traveler's diarrhea, which is what you're referring to. The more we use antibiotics, the more the resistance pattern builds up. A good example would be Campylobacter and the emergence of fluoroquinolone resistance. So the idea of using chemoprophylaxis for diarrhea, I think, has taken a step backwards as opposed to, say, 20, 30 years ago when we didn't have so many choices and we didn't see emergence of resistance patterns. However, if you do get diarrhea, which is non-bloody, I think there is a role for antibiotics in the setting of, say, reducing the duration of diarrhea, the shedding, And in that setting, I think a short course of azithromycin would prove useful. So when I do have patients who come to see us in the clinic, we do give them a script for azithromycin, explain the circumstances that you can use it, and then tell them, if you're having bloody diarrhea, all bets are off, azithromycin is not the drug, you need a workup. Why? It could be typhoid. It could be any other conditions that inflame the blood vessels and lead to bleeding. Whereas non-bloody diarrhea is usually limited to the mucosa, and the damage, therefore, from that is less. So you have to explain to patients what the diarrhea can look like. Most patients don't know what diarrhea is. Yeah, my stool was loose. How many stools did you have? One stool. That's not diarrhea. Thank you. Next. Things like that make a huge difference in educating the patients. So to answer to your question, I would probably say use azithromycin if you have a non-bloody diarrhea to reduce the stool as well as to improve the duration that you're symptom-free. But for norovirus, if the incubation period is so short and the duration of symptoms are going to be short, there's really no role for it.
My second question is unrelated, but I noticed on the polio timeline, we last gave oral polio virus in 2000, and yet there was a case of paralysis in 2005. I just was wondering about that.
And I think I looked into that from the CDC. I believe the reason was that person came from a country where the oral polio vaccine was given. So I believe that was the reason why.
What is the, say you have a rabies bite,
Yeah.
there's a delay there. How much time do you have to give the vaccine?
Sure. So it depends on the site of the bite. The closer we are in terms of bite to the central nervous system, I think the shorter the time you have. Say you get a bite on the foot, you probably have a couple of weeks, maybe a month or so to get it. I wouldn't tell anybody wait a month to get it, but you have time. But if you get a bite on the face, I don't know what's the right time to say. 48 hours, 72 hours, there's really no time that I can specify. But supposing the country or the part of the country that you go to doesn't have rabies virus, are we going to tell the patient stay there till we ship the virus? No, you probably want to tell them get to the part where, whether it be the embassy or whether it be to another nation that may have the vaccine and the immunoglobulin. So that's probably the way to approach it. Now, do you need the shot right away? No. You do have a time frame, but like I said, the area of the bite is important. So in terms of location, and then how soon can they get the vaccine? That's going to be the parts that determine it.
Kind of going more in the form of prevention for travelers' diarrhea, because with the whole resistance with Cipro and everything like that, regarding Pepto-Bismol, because that can reduce the risk by 50%, but taking 2 tablets half an hour before each meal, 4 times a day. But I'm really leery as to how long I want to tell people to use that. They say you can do it up to 3 weeks, but by that point they're going to be so constipated that life will not be very enjoyable for them.
Right.
So what kind of a time frame would you kind of feel comfortable with? Thank you.
Yeah. So the other thing to consider is the black stools that come from the Pepto-Bismol. Yes. A lot of patients don't like you once you get either of those. Like I said, with the ability to use medications like azithromycin, I think the likelihood of telling, hey, take chemoprophylaxis may wane and go out. Now, why am I giving you this kind of flaky stance? Well, let's look at IDSA. IDSA is the Infectious Disease Society of America. Came out with a set of guidelines in 2006 to look at travelers' infections, and they withdrew the guidelines within a few years. What does that tell us? It does tell us that we don't have anything solid to provide as guidelines. We do have to look at what the risks are and try to manage the risks with the least deleterious outcome. I did talk about infections. I did talk about antibiotics causing emergence of resistance. Let's talk about C. diff. Now, every antibiotic that we give, whether it be for treatment of diarrhea, upper respiratory tract infection, or cellulitis, has a risk for C. diff. Now, you treat somebody with an antibiotic in a part of the world and they come back and get C. diff. Now, have we made it any better? So one more nail in the argument that I personally feel for prophylactic use of antibiotics or antimicrobials, and then go into treat as symptoms emerge. in all of this, what we shouldn't lose track of is fluid replacement. When we talk about diarrhea, we never tend to think, oh yeah, if you know how to make an oral rehydration solution, that is going to probably help you more than, say, taking an antibiotic or taking an antimicrobial. So that's an aspect that I think I tend to promote more. I teach them, hey, you have a liter of water, use 4 teaspoons of sugar, 1 teaspoon of salt, and there is the basic oral rehydration salt that you can make. You don't need to boil the water. It just has to be potable water that's drinkable. So things like that. So with regards to Pepto-Bismol, it's been over a decade since I prescribed that. And I've tended only to go with short course treatment of azithromycin, and these days we don't even write scripts for Cipro anymore. So I hope that answers your question.
Okay, thank you.
Thank you.